Good morning and welcome. My name is Dr. Margaret McKinnon. I'm very proud to be the Homewood Research Chair in Mental Health and Trauma, and also a professor and the Associate Chair of Research in the Department of Psychiatry and Behavioral Neurosciences at McMaster University. It is my great pleasure to welcome you today on behalf of Homewood Health, Homewood Research Institute, and the Trauma and Recovery Research Unit at McMaster University. And today we're going to talk about minority stress in the workplace. But before I begin, I'd like to acknowledge that McMaster University is situated on the traditional territory of the Haudenosaunee and Anishinaabe nations and lies within the lands protected by the Dish with One Spoon Wampum Belt Agreement. That wampum uses the symbolism of the dish to represent a territory and one spoon to represent the people who are to share the land and take only what they need. We seek a new relationship with the original peoples of this land, one based in honor and in deep respect. May we be guided by love and right action as we transform our personal and our institutional relationships with our Indigenous friends and neighbors. And so, as a researcher, I feel very honored to be here today to talk about the story of our research with healthcare providers within the context of the COVID-19 pandemic. This work began as a result of a very generous donation from Homewood Health to Homewood Research Institute and has continued to be sponsored as well by the Public Health Agency of Canada. And as part of this conversation, we heard from healthcare providers across Canada, many of whom related stories not only about their experiences during the pandemic, but also their unique experiences as members of equity deserving groups. And I will never forget the bravery of Todd, who was a healthcare worker in Toronto, who shared his story with us during a symposium that we held in 2022. And he talked about the impact of his multiple identities on his experiences throughout the pandemic. That of being a man who belonged to the LGBTQ2SIA plus community, a man who belonged to the Asian community, and a healthcare worker. And here he described what he felt to be stigma and discrimination that he faced as a result of these three identities. And so as we talk about minority stress, which recognizes the stress that individuals experience related to their identities, may that be sexual, gender, racial, ethnic, religious, linguistic, related to immigration status in terms of acculturation and assimilation. We really want to talk about the everyday indignities that many people face related to their identities and to tell the stories of Canadian healthcare workers through these lenses. While we're speaking today about healthcare workers, I think it's important for us to remember that these stories apply not only to healthcare workers, but to a much broader community and communities. However, for healthcare workers who belong to equity-deserving groups, these stressors occur over and above occupational stress and the other general stresses of life and work. And what we often heard from healthcare workers in Canada is that their employers and their institutions appeared ill-equipped or uncomfortable talking about the impact of belonging to an equity-deserving group over the course of the pandemic, but now well beyond. And this town hall will discuss ways in which we can support healthcare providers with cultural sensitivity, with empathy, with compassion, with humility as we come to this table to have this discussion, and how we can create a supportive organizational and work environment that extends beyond individuals to also create a broader environment that embraces all Canadians. And so today's town hall will consist of a research presentation and of a panel discussion. The research presentation will discuss the concept of minority stress and highlight experiences of minority stress that healthcare providers belonging to equity deserving groups have encountered in their workplaces in Canada. And this will provide direct evidence from research that we conducted over the course of the pandemic, again, generously sponsored by Homewood Health, along with the Public Health Agency of Canada. And this panel discussion, we will then have a panel discussion where I'll be introducing some experts in the field of minority stress, and we'll focus on the different layers of experiences of members of equity deserving groups and explore the ways in which persons who belong to equity deserving groups can be supported individually in their workplaces and well beyond. And the audience will have the opportunity to ask questions through the Q&A panel, which you'll see below. Before we begin, though, I think we owe a huge debt of gratitude to those Canadian healthcare workers belonging to equity-deserving communities who participated in this work. So I hope each of you will join me in thanking those participants in the research who bravely shared their stories and you told us things that we found to be deeply concerning, but also which motivate change. And so I'd like to begin by introducing Dr. Anees Joseph. Dr. Anees Joseph is a postdoctoral fellow in the Trauma and Recovery Research Unit at McMaster University. He is generously sponsored in his work by Homewood Health through a donation to Homewood Research Institute. And he's going to talk about the research we did on minority stress as part of our Healthcare Salute research project that occurred over the course of the COVID-19 pandemic. Anisha's presentation will elaborate on the minority stress process and also resilience in the workplace and our key findings from this exploratory research. We'll also suggest potential future directions for collaboration, both with respect to the research environment, but also for clinical care and support. So welcome, Dr. Joseph. We're very much appreciate you being here and sharing not only your research experience, but also your clinical experiences of working with individuals who experience mental health and addictions issues. And as a postdoctoral fellow within our research unit, Dr. Joseph has been focusing on his research on minority stress among healthcare workers from equity-deserving groups here in Canada. I'd also invite individuals here to share their own identities, rather their own location and where they're joining us from. So we're really proud to have people from across Canada joining us here today. And we'd invite you to share where you're joining us from within the webinar chat. So welcome, everyone. And welcome, Dr. Joseph.
Thank you, Margaret. Hi, all. Thank you for joining us today. I'm happy to present the initial findings of our research on minority stress and resilience in the workplace. At the outset, I would like to thank Homewood for their generous donation through Homewood Research Institute that made this research possible. I would like to thank the team at Trauma and Recovery Research Unit at McMaster University under Margaret McKinnon, Homewood team, and all the healthcare workers who participated in this project. Since February 2021, a dedicated team at the lab have been working with healthcare workers across Canada to research, analyze, and document the impact of the pandemic on the mental health and well-being of healthcare workers and generate helpful tools and interventions to support them. These can be accessed at our Healthcare Salute website. This extensive research prompted us to look at minority stress and resilience with a view to understand the experiences of minority stress and its impact on the mental health and well-being of healthcare workers with minority identities. Let us begin by looking at the concept of minority stress and minority stress processes. Minority stress is the stress that individuals experience on account of their stigmatized minority identity, such as sexual identity, gender identity, ethnic or racial identity, religious identity, linguistic identity, immigration-related acculturation and assimilation. This chronic, distinct, and uncontrollable stress leads to adverse mental and physical health outcomes for persons who experience them. When it comes to minority stress, there are two types of stressors, known as distal stressors and proximal stressors. Distal stressors are external experiences of discrimination, violence, prejudice, microaggressions, whereas proximal stressors are internalized homo, bi, transphobia, identity concealment-related stressors, expectations of rejection. They both work through psychological mediation processes that create adverse mental health outcomes. As you know, persons tend to have more than one identity, multiple identities. Persons with multiple minority identities, such as sexual or gender minority persons from ethnic or racial minorities, tend to experience cumulative stress from these intersecting, disadvantaging minority identities. Let us now move on to the literature on minority stress processes in the workplace. Prior research has shown that persons with minority identities experience elevated levels of incivility, discrimination, and general lack of protection from unfair work practices. Healthcare workers with minority identities experience stigma-related stress and added occupational stress from discriminatory experiences from patients, co-workers, and unfair organizational practices. Some of the stressors that literature mentions are social fears of being othered, lack of culturally diverse mentors, exposure to microaggressions, and institutional ostracization. The literature also talks about minority stress and resilience. Minority stress theoretical framework conceptualizes resilience as integral to these experiences. Individuals show remarkable resilience to denigrating experiences of minority stress. Some of the factors that are vital to resilience are sense of community, social support, pride in their identity, and psychosocial or medical support. Inclusive policy environment and co-worker support are key factors in resilience at the organizational level. It is within this context of this literature that our research project was envisaged. Since there is a significant lack of studies that looked at minority stress at Canadian healthcare sector, our research project focused on understanding the occupational stress, organizational challenges, protective factors, and resilience among healthcare providers with minority identities. And we framed our research questions based on that. Healthcare providers with minority identities were invited to participate in surveys and/or in-depth interviews, and the data presented here are from these. We have used descriptive statistics and thematic analysis for understanding this data. Here I would like to present the demographic information on the data that we have collected for this research. The research participants, as you can see, are mostly females, though predominantly heterosexual in orientation and cis female and cis male in gender identity. The dataset includes a significant number of persons with sexual minority identities and gender minority identities. Majority of the participants fall between the age of 20 and 59. Professionally, they are predominantly nurses, followed by doctors, personal support workers, social workers, and occupational therapists. The PTSD scores indicate that within our data, 40.62% of persons with ethnic minority identities, 49.21% of persons with sexual minority identities, and 55% of persons with intersectional minority identities meet the cutoff for PTSD. The depression, anxiety, and stress scale show that within this data set, 55 to 65% of persons with ethnic minority identity, 61 to 71% of persons with sexual minority identities, and 64 to 72% of persons with intersectional minority identities reported mild to extreme symptoms of psychological distress. We will now look at the themes and sub-themes that we have identified from this qualitative data. Our qualitative side of the research is exploratory in nature. This presentation is reporting on the data from 5 in-depth interviews with healthcare providers with minority identities. These initial findings will be used for further research. A major theme that came through in the data was the experiences of minority stress that the participants have gone through, with experience of stigmatization and discrimination, and everyday struggles and internalized stressors as sub-themes. Under the key theme, organizational challenges, we have work culture and microaggression, and organizational policies and practices as sub-themes. The theme protective factors and resources has resilience and protective factors and involvement in social justice activism as sub-themes. Now we delve deeper into themes. The participants go into detail about their experiences of identity-related stigmatization and discrimination at their workplace. Their experience range from questioning their credentials, being sidestepped on career growth opportunities, having to work harder than others to prove themselves, having to educate co-workers about their identity, stereotyping, shaming, exclusion, and aggression. As you can see in the quote, I actually did quit this job, you know. He quit the job as well because he felt he was being mistreated. I agreed. Everyday struggles that relate to their identity tend to amplify their inner struggles, such as negative self talk, constant ruminations, identity concealment, fear of safety, fear of rejection, resorting to self harm, or substance use to cope with these stresses. As the quote shows, I don't sleep, I think about it. I think about what I could have done that was different. I wonder about the impacts on my socioeconomic status. Will it mean that I lose job? Will it mean that I lose my house? Will it mean that I won't be able to provide for my kids? The largely white, heteronormative, and cisnormative work culture with social pressure to conform to it can be stressful for individuals from minority identities. Lack of representation, or the burden of constantly representing minority communities within the organization, colleagues being mean, and conscious or subconscious microaggressions at the workplaces can be invalidating experiences for them. As the quote shows, I feel like I do sometimes get questioned more on certain things, and ironically, especially when I am around things to do with sexual identity. While the EDI efforts at the organization are appreciated, research participants shared that such policies and practices often remain performative. Translating well-written policies into everyday practices of inclusion, respect, identity affirmation, and genuine support is what they are looking for. The quote says, but yeah, otherwise, we do have a lot of diversity and equity initiatives at our hospital, and I really do worry, like, is this all just performative? Is it? Because I'll only really believe it when I see that top panel more diversified. Community connectedness, social, familial, friendship support are key to their resilience. The participants have felt that their experiences of overcoming challenges in their own journey have become a huge source of resilience while encountering discrimination and stigma at their workplaces. Formal support such as therapy, mental health support have been protective factors for them as well. The quote says, I think that it means that I don't take any of it for granted. I appreciate. It gives me an appreciation of my own diversity and for the diversity of others, and just gives me that appreciation that other people can be and will be more diverse than I know and I understand. I think that's a big one. As an extension of community connectedness, being part of social justice activism, advocacy, and social movement have been important aspects of their resilience. As the quote says, I think I became more interested in social justice and that kind of area of research and stuff. I just felt more motivated to understand and label that all the experiences that I have had. To conclude, the results of this study indicate that there is a need to strengthen structural resilience at the organizational level to enhance individual resilience to minority stress. Cultural sensitivity and humility in providing support, in being empathetic to their struggles are important part of creating a culture of support within the organization. All these can be anchored on adopting a trauma-informed organizational culture. Thank you, and this concludes my presentation.
Thank you so much, Dr. Joseph. And what I'd like to do before we begin our panel discussion is acknowledge that this research was led by Dr. Andrew Nicholson, who's now in the Department of Psychology at the University of Ottawa, along with serving as the Director of Clinical Research at the Atlas Institute in Ottawa. So thank you very much, Andrew. And he was also, I know, very much assisted by Sandhya Narakuzi, who's a graduate student in the graduate program in neuroscience at McMaster University. So thank you very much, and thank you to Dr. Joseph and to Dr. Kim Ritchie for their amazing work on the analysis of these data as well. So as we began this research, we really took the view that this wasn't about just characterization, which I think is often a folly in research, is that we characterize experiences, but we don't move forward. For example, to stimulate policy change, to create evidence-based resources, to support individuals from equity-deserving communities. And often we also don't thank and acknowledge those who have shared so generously their stories. So I also want to say again to all of our research participants, thank you so much for sharing what I think is a very intimate part of identity that really can be difficult to talk about. And we just thank you again for your generosity in sharing these stories. And so what we're going to do now is we're going to move into our panel discussion where we have three experts with us today talking about their clinical and research experiences with minority stress, their experience developing programs and implementing them at various levels of organizations, and also their work to provide culturally sensitive mental health care. And really, this conversation will touch upon various aspects of experiences and also reflect upon how we can move this work forward from characterization to the development of resources to support members of equity-deserving groups, to improve mental health care and mental health and well-being supports, and also to transform policy, both in organizations, but also at the local, the provincial, and the national level, along with the international level, as this work moves forward. So it's my pleasure to welcome our three panelists. Our first panelist is Dr. Anne Mullane, who's a registered psychologist with more than 25 years experience in the provision of employee family assistance programs in community mental health, in psychological assessment, and in substance abuse treatment. And her areas of expertise include clinical diagnosis, concurrent mental health, substance abuse assessment and treatment, and clinical supervision. And she also has very extensive experience treating depression, anxiety, and trauma-related conditions. Dr. Mullane is responsible for leading Homewood Health Incorporated's national clinical service delivery and clinical network. She oversees service delivery in two primary divisions, the stay-at-work services, the EFAP program, in crisis management services, in organizational wellness, and in return to work services, along with psychological assessment and disability management. So a very busy portfolio. Dr. Mullane provides leadership to ensure clinical quality across all Homewood outpatient and inpatient services, and it's been my great privilege to work with Anne now for well over a decade on this work. I'd also like to welcome Dr. Andrew Nicholson, who is an assistant professor within the School of Psychology at the University of Ottawa, and is also the Director of Clinical Research at the Atlas Institute for Veterans and Families at the Royal Ottawa Hospital. As a scientist at the University of Ottawa's Institute of Mental Health Research, he also holds the Atlas Institute Chair for Minority Stress and Trauma Research. And I think that really speaks to Andrew's efforts to move forward this area of research and to be a real leader in this domain. His research focuses primarily on uncovering the neurocorrelates of post-traumatic stress disorder, or PTSD, and other trauma-related mental health conditions. His work also aims to develop innovative treatment approaches for post-traumatic stress disorder, including neurofeedback, while also investigating the neural mechanisms of trauma-related conditions. And finally, I would like to welcome, and I should also mention I've worked with Andrew for well over a decade as well, and that's been a real privilege. So thank you, Andrew. I've known you since you were a student, in fact. And finally, I'd like to welcome Dr. Hugo Schlecki. And they serve as the Trauma Services Development Lead for Homewood Health Centre and the Centre's Traumatic Stress Injury and Concurrent Disorders Program in Guelph, Ontario. Dr. Schlecki specializes in the assessment and treatment of trauma-related disorders, including very prominently trauma-related dissociation, which I think is often an underserved poorly understood area of response to trauma, and Dr. Stuckey is a tremendous leader in this area, and also that it works very heavily in facilitating trauma-informed collaboration. So welcome to all of our panelists. Before we begin our conversation, we have prepared questions, but I'd also very much like to invite the audience to submit their questions using the Q&A function below. So if you would like to submit a question, please just click on the Q&A tab below. You'll be able to type in your question and I'll read that aloud to the panelists. Thank you. So Dr. Nicholson, I'd like to begin with you. So your research concerning minority stress has been a very important contribution to the field. Could you please talk about your research surrounding minority stress and also how the impact of minority stress on the mental health and well-being of persons from equity-deserving communities?
Yeah, absolutely. Thanks so much, Margaret, and thank you for inviting me to be part of this panel discussion. And thank you for the introduction as well. So our research really focuses on this phenomenon that has been repeatedly shown in the literature in terms of exposure to minority stressors have been repeatedly demonstrated to be associated with certain mental health outcomes. So this can include things like elevated rates of PTSD, mood and anxiety disorders, substance use, body image alterations, and kind of the list goes on and on. And I think this is really reflected in the data that was just presented as well. What is really not as well understood is how we go from point A to point B. So how does those exposures to chronic stress and oppression on a neurobiological level, how do we end up with either increased risk or resilience for mental health outcomes? And that is what our group is currently trying to uncover by investigating neural pathways of minority stress among sexual orientation, gender minority, and racial and ethnic minorities as well, and really focusing on a intersectional perspective of how multidimensional identities encounter and experience those minority stressors, and again, how that may lead to various mental health outcomes.
Thank you so much, Andrew. And I think really acknowledging that intersectional identity, that all of us have multiple identities, and often we can be pigeonholed into one particular community where we need to identify the whole of our experience. I want to also acknowledge here the LGBTQ Purge Fund, which has generously sponsored some of this research surrounding the neural correlates of minority stress. And that really is a group that has, I think, so fiercely represented military members and veterans who were removed from the Canadian Armed Forces during the LGBTQ purge. I think that was a tremendous loss to Canada of individuals who could have made tremendous contributions in their careers. And we're very grateful for the support from the LGBTQ Purge Fund as well. I just wanted to mention that. Dr. Mullane, could you please talk about some of the organizational initiatives that you have implemented or that you're aware of that can assist in addressing the challenges of minority stress and some of the resulting mental health challenges that Dr. Nicholson has described?
Sure. I would say that a part of it is consciously developing a structure within the organization that looks at diversity, equity, inclusion, that provides both full-time support for somebody to focus on that, as well as having executive sponsorship and participation in those initiatives. I think that having a strategic plan that really looks at how are we going to introduce this and continue to focus on minority stress, as well as other kinds of resilience building and acknowledgement initiatives and activities. For Homewood, we did hire a full-time inclusivity manager whose sole job is, it's a big one, but I'm not doing it off the side of her plate, is really focused on our strategic plan, leading the implementation of that plan, providing training, consultation to staff, And she's not working with clients. She's supporting staff to do the work with
Yeah.
clients and supporting staff to implement amongst each other within the culture. Support and acknowledgement for various equity and deserving groups. There's a number of things that she leads that are monthly, quarterly, and have annual kind of review. I think it's really important. We have a steering committee with a number of people from various parts of Homewood across the country. But that steering committee is sponsored by and led by two Homewood executives. So myself, and our executive vice president of people and culture, which is typically thought of as HR. So having two executives there at every steering committee meeting, part of the strategic planning, part of sort of looking at the feedback that we're getting from staff. I think those are all really important things in order to try and implement and embed it within the culture of a workplace.
Thank you so much, Dr. Lane. I think that emphasis on hiring an individual who's dedicated to this, having executive sponsorship, organization-wide, because we certainly know that if we have, representations of equity, diversity, and inclusion that in an environment that is not truly safe, that is actually more harmful and causes harm, right? And so that leadership support, that individual dedicated to this and embracing this across the entire organization, just a really thank you for providing that guidance. Very much appreciated. I want to turn now to Dr. Shilka. So, Dr. Shilka, you have been involved in supporting individuals who experience trauma-related and dissociative disorders. Could you talk about your clinical experiences of supporting individuals experiencing minority stress and some of the important work that you have done?
So, well, thank you for the question, and so glad we're doing all of this together and good to be doing this with each of you. So people who come from one or more marginalized equity deserving groups who are also experiencing PTSD in relation either to experiences related to marginalization or separately do face that sort of additional challenge, right? So just like we talk about intersectionality, the more challenges you face in terms of belonging to groups or having experiences that are not prioritized or not valued by the majority of culture, the more challenge you're going to face. And so, if you're coming from one or more marginalized groups or equity deserving groups, on top of whatever other challenges you have, you are going to be facing more difficulties. One of the best indicators of higher degrees of symptoms is higher degrees of stress, and the term minority stress certainly applies here. And by virtue of belonging to one or more marginalized or equity deserving groups, you're also more likely to have experiences that can lead to heightened stress and stressors and or trauma. So it very much is two lenses that very much impact each other for sure.
Well, thank you so much. And I know many organizations and individuals are here thinking about how they can apply some of the research findings or some of the information to their own organizations or to their own clinical practices. From your own experience at Homewood Health, can you talk about the ways in which one could start this process of providing culturally sensitive clinical supports in this case?
Well, I really love and want to echo everything that Dr. Mullane indicated in terms of starting with the system.
Mhm.
You know, what we model, we tend to do, right? And what we see modeled by leaders, we tend to do. As we know from other research that we're involved in together, when you look at trauma-informed collaboration, which is a good like when you have high levels of trauma-informed collaboration, you have lower levels of challenges related to diversity, equity, and inclusion. And so we know that when that's demonstrated at a leadership level, that you have when TIC is about demonstrated leadership level, you have higher likelihood to feel included and involved and wanting to stay in the organization. And when the opposite is true, the opposite is also true there too. So I'd say a big thing there, but the other big piece is really working for the entire organization to understand what it means to be trauma informed in how we collaborate.
Mhm.
Um, you know, the one of the maybe quickest way to summarize trauma informed collaboration is that it looks at the 6 principles of trauma informed care, but make sure that we're recognizing that the best way to notice if an interaction is trauma informed is by the quality of the interaction. Do the people involved feel emotionally safe? Are the interactions seen as trustworthy and transparent? Do people know why the other person's doing what they're doing and what to expect in the interaction? Is that actually followed through with and met by the expectation? Are they actively involved in sharing influence? Are solutions looked for that are looked to be for best mutually benefit, right? So win-win solutions. Is there demonstration of curiosity about information or suggestions or experiences that the person, particularly someone's from more privileged groups, has the opportunity to understand things they might not otherwise, right? So that curiosity about what you may not know yet that would lead to better understanding and better decisions. Um, are people actively encouraged to speak up and modeled that that's okay and recognized for when they do? And is that information then put into practice? Right, that's part of the trustworthiness piece as well. And are we actively working, particularly uh, consciously and intentionally, to actively include folks who might belong to one or more marginalized groups because we all uh, well, I shouldn't say we all know. Many of us know, and many of us understand that when you've been experienced, when you belong to one or more marginalized groups, you're likely to have had multiple experiences where your perspective actually wasn't valued, even if you did share it. And
Yeah.
so it's going
Yeah.
to be, uh, as you were talking about before, like if we name DEI, but we aren't actually demonstrating equity and inclusion, it can be more harmful, right? It's that lip service that one of the participants in Dr. Joseph's study was talking about, and that actually makes people more upset, right? Because it's
Yep.
so are we working particularly intentionally to make sure we're hearing from people who might otherwise not might worry that their voices might not be heard? And are we acknowledging that we are absolutely going to make mistakes along the way?
Yeah.
And what's most important is that we address those in a way that's consistent with the principles of trauma-informed collaboration that we just summarized here. So it really is an ongoing process. And if we're doing that with each other as a team and we're kind of living and breathing this approach to interacting with ourselves and each other, that of course is going to come out in the patient work as well. Um, and we absolutely want to make sure we're following each other's principles in that work.
Thank you so much, Dr. Shoka. And I think that the principles of trauma-informed collaboration are so relevant to this conversation. I would say as a clinician scientist myself, I think acknowledging experiences of equity deserving groups in clinical care is so important as a starting point. It's certainly not an ending point, but a starting point by being curious, being empathic, and being open to the conversation. I can also say from giving
Mhm.
talks, both nationally and internationally, when experiences of minority stress are actually discussed, it's
Mhm.
amazing to see the number of nods of the head and how
Mhm.
people feel seen and heard when
Mhm.
we talk about these
Mhm.
experiences. And I think that's very important for clinical
Mhm.
practice as well as for organizational support. So thank you so much. And I think you've
You're
really
welcome.
addressed one of the questions that I see in the chat around what is the best approach for employers to take to minimize stress among equity deserving groups. Maybe stress is not, you haven't necessarily addressed stress, but certainly principles that we can
Mhm.
rely upon. I'd like to turn to another audience question. So Dr. Nicholson, what are some of the protective factors in the literature that may contribute to resilience or lowered risk of deleterious mental health outcomes?
Yeah, thank you for that question. I think it's interesting some of the parallels with the PTSD literature, where one of the kind of most replicated, I guess, protective factors has been surrounding social support, and we know that to be true for
Yeah.
many trauma-related disorders. and also finding a sense of community, self-acceptance as well. Um, while we're on the topic of self-acceptance, I did want to mention a few thoughts I had
Sure.
um, during the previous question. And I was thinking of some factors that are particularly relevant for a healthcare worker population
Mhm. Thank you.
and addressing minority stress within these groups. So during the presentation, we heard about different minority stressors, distal and proximal stressors. And one of the proximal stressors are how someone internalizes negative societal beliefs about a stigmatized identity and how someone can really internalize that deeply rooted sense of shame. And often among sexual and gender minorities, for example, this development of chronic shame is occurring, quite early in life and is really embedded in someone's identity. And what we found with some of our work is that to counteract that deeply rooted shame and internalized stigma, people will often pursue career paths that can validate their identity and kind of counteract that deeply rooted shame. So, healthcare workers in Canada, especially, are often a very highly respected profession, especially physicians. This is a very um, prestigious occupation, and I think that in some of our work as well, we have seen people can adopt as well perfectionistic traits to counteract that shame. So when we're thinking about the effects of minority stress in a healthcare worker population, and we talk about that additional stress in relation to the occupational stressors everyone is experiencing, I think we also have to consider how this occupation is serving as a way to um, counteract that deeply rooted feeling of shame. And although many people in that profession will take on that role as part of their identity, it might have a bit of a nuanced meaning in this context because it's not only part of your identity, but you need that identity to feel worth.
Yeah.
And I think that can be an additional layer of you're experiencing stress, you're also experiencing minority stress on top of that. Your occupation is part of your identity. But then in this context, what are you without that
Yeah.
identity? And that can be very, painful for people. And I think uh, especially when individuals are really defining their self-worth on their accomplishments and their occupation. But I was just kind of mulling this over while you both were talking on the previous question and answer period. But yeah.
Thank you, Dr. Nixon. I remember some time ago you recommended an excellent book to read, which was The Velvet Rage. I don't know if you want to comment just briefly on that book. I think it's excellent.
Yeah, I think it talks a lot about this calibration of identity and the fusion of shame with identity and how at different kind of stages in one's acceptance of their sexual and gender minority identity, how people can kind of grow and learn to live authentically and without that attachment to external validation. Oh, I just see a comment. So the book is called The Velvet Rage. There's also a great book called Treating Trauma in Trans People by Reese Minshaw as well that I recommend. But yeah.
Thank you, Dr. Nicholson. Thank you. So I want to also return to the audience questions. So one question was around how these findings will be shared. The Trauma Recovery Research Unit at McMaster, in partnership with all of our many partners, St. Joseph's Healthcare Hamilton, Homewood Research Institute, Homewood Health, we've mounted a website called canamers.com, which we're very grateful for the sponsorship of the Public Health Agency of Canada. We will for this website, and we are actually in the process of mounting a minority stress module on this website that will be accessible for all Canadians. It extends beyond healthcare workers to include civilians, public safety personnel, other essential workers. But much of this information will be mounted there, along with resources and pointers towards tools that healthcare workers and organizations can use to support others who experience minority stress. And I'd really also like to refer people to the excellent work of Monica Williams at the University of Ottawa, who's rather studies racial trauma. She provides some excellent trainings online for clinicians surrounding racial trauma and has been a real leader in this field. So I'd also refer you to that work as well. I think it's really important. I'm going to return to another audience question just because I think it's really important that our audience has the opportunity to ask questions. And so this is a question, sorry, I just need to go back. So this is a question focused on the Canadian experience and how, rightfully so, there's been a tremendous focus on the experiences of individuals belonging to Indigenous communities, so to Métis, Inuit, and First Nation communities. And so the question is, how can we within Canada also expand some of the, I would say, the federal focus in part on other equity deserving groups as well, without minimizing in any way the focus on Indigenous people. So I wonder if any of the panelists would like to address that question.
I can address that. I know that we have, particularly at some of our facilities, very much focused on Indigenous and communities and their needs and how it fits with truth and reconciliation. But I think it's the overall DEI strategy is focusing on all equity deserving groups. And I think there is so much intersectionality within all of the groups that trying to separate out one versus the other sometimes becomes more of a buying into the colonized sort of viewpoint. There's not enough to go around. But I do think that the more we open people to thinking in a way, to being aware of our own biases or our own just assumptions,
Mhm.
right? Culture is what everyone knows that everyone knows, but everyone knows something different. And so we forget that what we know are our assumptions. I think the more we're able to really widen that lens to be introspective and aware of assumptions, that it opens us up to being able to see different from different perspectives. And that perspective taking, I think, is very important. I also think it's important to, throughout the year, in terms of what we do as an organization, to spotlight various cultural groups and their contributions. Not only the sort of what may be particular minority stress and hardships, but what are the things that various equity deserving groups bring
Yes.
to the
so-
culture that widen our perspective and make more room and possibilities for all of us.
Thank you, Dr. Mullane. And I think so much comes to the table. So much comes to the table that enriches everyone.
Mhm.
Um,
Exactly.
I want to ask you, Dr. Shilka, you've been very much involved in taking these research findings and transforming them into clinical practice and clinical care. I wonder if you could talk a bit about that experience and what you, Homewood Health, and others have done to really build upon these key findings. Because again, we can characterize for the next century, but we need to take action from these findings.
Mhm. Thank you for the question. I think, a big part of this is leading with something that you emphasized in our last conversation about the last question, which is that curiosity.
Yeah.
So what don't I know or understand yet? When something's happening that doesn't make sense, to lean into curiosity, right? Often when we don't understand something, it can be difficult, and it can be a situation where we are wanting our old ways of doing things to work. And when they don't, that can lead to frustration instead of curiosity. And so I think leading with curiosity about others' experience, but also about how my experience of the world might be shaping my experience of the world. So how my identities might be impacting how I'm walking through the world, what what gets shown to me, what doesn't get shown to me. So as Dr. Mullane was speaking about, starting with, you can talk about it in terms of cultural competency. You can talk about like building improved understanding of the impact of culture, but noticing where am I located in the culture, right? What am I of what groups do I belong to in terms of uh, if any of these I'm more likely to be privileged? Am I white or am I someone who's of BIPOC background? Uh, am I male or am I uh, female or of a gender expansive or trans identity? Am I heterosexual or am I um, most attracted to uh, people of the same sex or have a wider net of people who I'm attracted to, right? Which cultures do I belong to? Um, which ways do I show up in the world, and how does that impact things? Because I think one of the things that's really important to notice is that um, cultural narratives structure everyone's experience. To go back to what Dr. Mullane was saying, like it's what everyone knows, right? But it's also what hems everyone in. And so cultural narratives can keep people also who fall into the category of privileged groups from being more authentic to who they are, because the narrative still constrains them. It's just harder often for them to notice that that's the case. And of course, people who aren't privileged then have the double challenge, right? Because they both are structured into a bit of a box and also don't have the privilege. So really helping everyone get curious about what do I not know yet here, and learning more, leading with questions, and sharing what we know so far about each of these things. So Dr. Nicholson shared some pieces of information that I'm so grateful he did in terms of what we know about the impact of early experiences for people who have been marginalized, and that shame and how that drives them as healthcare workers, for example. So we're thinking about treating healthcare workers. That's exactly the kind of specific information that we want to make sure our providers are aware of. Um, when it comes to, it's absolutely true. We want to make sure that we're broadly inclusive and that we're specifically curious. That both those things are true, right? And so with each group that we're working with, anytime I'm working with someone, I don't presume to know uh,
Yeah.
what they know or to be able to know exactly what they experience. So it's then leading there too, making sure you also do things like letting people know that you're actively interested. If you're misunderstanding something, you're missing something, or you feel like they feel like you don't quite have it right, that they're actively invited to let you know that, so because you're interested in learning how to be a better help. It shouldn't be anyone's responsibility to educate the people they work with.
Yeah.
And the only way to improve working relationships is making sure there's enough emotional safety to point out when there are misunderstandings and pieces of information that would be helpful.
Mhm.
So it's about education, separate from the interactions, but it's ongoing curiosity in the interactions as well. And for people who are interested in learning more about different diversity and equity deserving groups, let me see, there's a link, I can put it in the chat actually, to a site
Right.
for the Canadian Center for Diversity and Inclusion. There's no one perfect depository of all information that's helpful, but this is one link that leads to a lot of sublinks, lots of pages that are useful and helpful, lots of reports, lots of studies. So to get curious, what don't I understand just yet? What don't I know just yet? And that site's a good place to start to educate yourself and continue to get more curious.
Thank you so much. And, we will send these links out by email to everyone who attended and also to those who couldn't join us today so that people can have access to this information. And thank you so much for sharing that. I think that notion that we don't know others' experiences is very important. And I want to thank that Pinder Dodig, who I see is attending today, for really teaching me that we don't know other people's experiences and we need to ask the questions to better understand. I also want to acknowledge that we talk about minority stress in terms of stress, but I think in many ways it's also trauma. There's a form of trauma that is often analogous to what people experience when they develop post-traumatic stress disorder. Criterion A in the DSM is unfortunately very narrow in this regard, but this is repetitive chronic stress and for many individuals trauma. And I think there's great power in acknowledging that this is traumatic experience as well. I don't know, Dr. Nichols, if you wanted to talk a little bit more about that, the overlap between some of the concepts related to minority stress and to PTSD.
Yeah, absolutely. We published a review paper a few years ago now, looking at just a systematic review of some of the brain imaging studies that have been done among sexual minorities. And although minority stress oftentimes is not measured in previous studies so far, we are beginning to see interesting parallels between some of the functional brain changes that we see in the context of PTSD and the aftermath of trauma. So, some of these changes being alterations in the salience network, which is really responsible for defensive fight or flight processing and involves a lot of the survival kind of brain structures. And, I think that really makes sense if someone is experiencing chronic stress that is identity based, that is occurring across, development. It makes a lot of intuitive sense, right? That we would see alterations in how the threat and innate alarm system becomes calibrated. Additionally, there's a term that's been coined to exactly kind of pinpoint this problem that you highlighted, Margaret, of the criterion A being a bit narrow, and it's historically served certain populations and has excluded others. So the term insidious trauma refers to those pervasive experiences of minority stress that can lead to trauma-related symptoms without needing to centralize a specific criterion A index trauma, because it's been shown that minority stressors that would not meet criterion A definition is predictive of PTSD symptoms. But then the point I just want to end with is that this whole, dichotomy is this doesn't really hold up in reality, because we also know that minority stress experiences are oftentimes co-occurring with criterion A traumas, and certain events can fit both the definition of minority stress and criterion A traumatic events. So, for example, some forms of discrimination or hate crimes, those could fit both. So oftentimes there's this co-occurring component as well, which makes it very difficult to separate those trauma exposures. But yeah, I just wanted to highlight some of the complexities there.
Thank you, Dr. Nicholson. I know we are at the top of the hour. There is so much more that we could talk about. This went so quickly. I think we may have to come back and do another symposium on this. But Andrew, I wonder if you could just talk very briefly, just on a closing note, of some of the erroneous representations in research. And I'm thinking about the work of PRISM and some of the neuroimaging findings, because I think it's really important for researchers joining us to be aware of that particular paper that we were able to challenge directly,
Mhm.
as you will recall. Yeah.
Yeah, I think one of the um, problems with especially neuroimaging research is oftentimes it's contrast based, which means you're comparing two groups and looking at the differences between groups, and you're really siloing aspects of people's identity. And many studies, especially among sexual and gender minorities, have just been comparing sexual and gender minority groups to either heterosexual or cisgender control groups. And they're really attributing all of those differences to either the neurobiological basis of sexual orientation or gender identity. But what's really important is that many of those studies are failing to account for minority stress exposure and insidious trauma exposure. And we really see that when reviewing those papers. All of the brain differences we're seeing are in the innate alarm system and the survival brain. So I think that really highlights where we need to move forward, especially with the neurobiological studies, but additionally bringing in more multivariate, multidimensional analysis techniques, so things like machine learning, to really capture the intersectional identity of someone and their unique experiences based on those identity factors, instead of siloing people based on either sexual orientation, gender, race, ethnicity. So really incorporating that um, minority mosaic of someone's identity and the complexities there, and that being reflected in the research.
What an important note to end on, to talk about our multiple identities that we all hold. You've done a lot of important work on the minority mosaic, and we can refer people to your work surrounding that. But also remembering that, such false comparisons are made and just how important understanding of minority stress is, both from a research, but also I think really critically from a clinical and a policy perspective as well. So I'd like to just conclude by thanking the individuals who participated in this research firstly, and I think primarily for again for telling their stories to help to move this work forward. I want to thank Dr. Anish Joseph for his wonderful presentation, to our panelists, to Homewood Health for sponsoring this symposium. But also, finally, I want to really thank the members of the audience as well for joining in this conversation. I think, as was highlighted, we are going to make mistakes in this work. I know I've been certainly guilty of many mistakes myself, but I think we need to have the bravery to go forward with discussing minority stress, racial trauma, and other forms of inequities, because we really need to move things forward and not sit in our hands. It has been done for so many years. So thank you again to everyone. We're deeply grateful. And I'd also like to thank Dr. Andrea Brown, Dr. Kim Ritchie, Matthew McKinnon, Austin Talley, Chris Steff, and many others who assisted in organizing this symposium. We're just very grateful as well for your efforts too. So thank you so much. And I hope Sandhya is watching to thank her for her excellent work as a graduate student on minority stress. So thank you, everyone, and take good care.